So today, we're aiming to tackle a big pressing question for the field of long-term care and workforce development. Given the recent and potential federal investments in state Medicaid programs, we ask, how should states best use those funds to invest in the direct care workforce? Before we get to the content of this webinar, I want to introduce you to who we are as an organization in case you're not familiar with us. At PHI, we're a nonprofit research and consulting firm, and we recognize that strong relationships between direct care workers and their clients or residents are really at the heart of quality long-term services and supports. But we can only achieve those strong relationships when workers receive a living wage, high quality training, and overall respect for their very important roles. We strive for this vision of job quality and care quality through a combination of producing original data and analysis, advocating for this workforce, and working directly with employers on the ground to implement elements of a high quality direct care job. And importantly, all of these services and activities that we carry out inform each other. So the high level policy advocacy and research is informed very much by the on-the-ground experiences of employers and workers. For today's webinar, we have three primary goals. By the end of today's discussion, we hope you'll have learned about the current and future opportunities for federal investment in the direct care workforce, that you'll understand how states are capitalizing on new sources of federal funding, and you'll gain a new understanding of how PHI can help your state or your organization develop new research and strategies to support the direct care workforce. We have a stellar panel to sort of answer this pressing question that I raised at the top of the webinar. First, we'll hear from Andrea Price-Carter, the Manager of Congressional Affairs at LeadingAge, who will share the current and future opportunities for states to leverage federal funding and invest in the direct care workforce. In her role, Andrea focuses on the critical issues impacting LeadingAge's provider members and 38 state partners. She engages with elected officials and other stakeholders to advance before Congress and the administration policy priorities and legislative initiatives that address crucial issues, including the workforce crisis and aging services and the use of telehealth and technology to benefit older adults' care. Prior to joining LeadingAge, Andrea worked at the National Association for the Support of Long-Term Care, as well as AARP, and in both roles, she also worked in government affairs. She began her career as a legislative staffer for former US Representative Louis Payne, and then for former Virginia Governor Douglas Wilder. In September 2019, she was appointed as a commissioner for the Prince George's County Human Relations Commission in Maryland, which is responsible for investigating and adjudicating discrimination practices within the county. She has a Bachelor of Science degree in Macro Environmental Studies and Design from Howard University, and a Master's of Public Administration with a concentration in public policy from Clark Atlanta University. After Andrea, we'll hear from Patti Killingsworth, Assistant Commissioner and Chief of Long-Term Services, Long-Term Care Services and Supports in Tennessee, which is, or at TennCare, Tennessee's state Medicaid program. She'll share how her state is leveraging federal funding to improve direct care jobs. Patti is a lifelong caregiver. She is a nationally recognized leader and highly sought after expert and advisor in home and community-based services, managed long-term services and support, value-based purchasing for LTSS, and initiatives to improve care for beneficiaries who are dually eligible for Medicare and Medicaid. She's worked in Medicaid programs for over 2 decades, leading systems redesign initiatives in multiple states. Welcome, Patti. And finally, last and certainly not least, we'll hear from Jess Mauer, the Executive Director at the Maine Council on Aging. And Jess will speak to her organization's priorities regarding recent federal investments in Maine's direct care workforce. As the Executive Director of the Maine Council on Aging, Jess leads and manages a broad multidisciplinary network of more than 120 organizations, businesses, and community members working to ensure we can all live healthy, engaged, and secure lives as we age in our homes and communities. In this role, she advances statewide public policy initiatives, provides leadership within Maine's Aging Network, and supports Maine's Legislative Caucus on Aging. Her areas of specific focus include housing, transportation, workforce, including the direct care workforce, lifelong communities, and care across settings. She oversees the Maine Municipal Data Across Sectors for Healthy Aging Initiative, the Maine Power and Aging Project, the Equity and Healthy Aging Initiative, and the Tri-State Learning Collaborative on Aging, a regional learning collaborative aimed at increasing the collective impact of community-driven aging initiatives. She annually organizes statewide and regional events that advance aging policy, including the Maine Wisdom Summit. She co-authored Building a Collaborative Community Response to Aging in Place and Maine's Blueprint for Action on Healthy Aging. A licensed Maine attorney, Jess worked for 17 years in the Maine Office of the Attorney General, and she graduated from the University of Maine School of Law and the University of Massachusetts at Amherst. So welcome, Jess. Before we hear from our panelists, I'd like to provide brief framing remarks about why we're coming together here today. Namely, we're facing a direct care workforce crisis in this country across occupations, including personal care aides, home health aides, and nursing assistants, and across settings from home and community-based services to nursing homes. Demand for these workers is extremely high, a trend that is driven primarily by the rapidly growing population of older adults across states. From 2019 to 2029, the direct care workforce is projected to add nearly 1.3 million new jobs. That's more new jobs than any single occupation. However, job quality has not kept up with this demand. These jobs are typically characterized by low wages, a lack of professionalization, and limited opportunities for advancement, among other concerns. As a result of high turnover, as well as an aging workforce and workers who become disabled or leave the labor force for other reasons, the total job openings we'll need to fill from 2019 to 2029 is actually going to be 7.4 million. That's the second most total job openings in the country. To bend the curve on job openings and to ensure high quality care for long-term care consumers, a holistic approach is needed to address every facet of job quality. And I want to acknowledge that states have made steady progress to address this crisis, but definitely more progress and more investment is needed. The policy changes we've seen in recent years primarily have these three aims in broad strokes: lifting workers out of poverty, improving data to strengthen the workforce, and investing in workforce innovations to encompass a range of other job quality elements that maybe aren't directly related to compensation. Regarding lifting workers out of poverty, over the past few decades, we've seen 22 states enact wage pass-through legislation or policy. That's according to the Institute for Healing Justice and Equity. These policies help ensure some proportion of reimbursement rates or rate increases make it into the hands of direct care workers. Also, regarding data collection, Texas recently adopted a model from Washington State and added new questions to its state cost reports, which provide critical data on recruitment, retention, and compensation of direct care workers under the state's Medicaid programs across settings. These data help the state better understand the size, scope, and distribution of workforce challenges, and they also offer critical insight to evaluate policies and practices and make changes over time. Finally, regarding innovation, New York State recently established the Managed Long-Term Care Workforce Investment Program through its 1115 waiver. Before it ended last year, this program provided critical funding to develop training and advancement opportunities for New York's direct care workers that wouldn't be available under current Medicaid funding levels. So these are all interventions that could be scaled up or replicated, but with the litany of policy and programmatic options available to states to invest in the direct care workforce, it can be challenging to determine where to start or how to proceed. So as your states navigate these issues, I want you to know that we're here to help at PHI. Over the past 30 years of our organization's history, we've developed deep knowledge about the policy and practice landscape and workforce development, which we can leverage to support your own workforce development efforts. Our services include surveying the direct care workforce, producing rigorous research reports on your state's workforce, making a powerful data-driven business case, which can inform advocacy efforts, legislative proposals, and other efforts, developing novel recruitment and retention strategies, informing the design of various direct care workforce policy interventions, diagnosing direct care workforce training infrastructure needs, launching a social media publication education campaign, advising on the creation of new data collection systems, and bringing expertise to convening a statewide direct care worker task force. So building on our experience over the past few decades, these are all services that we can bring to your state if you're interested. So if you're interested in learning more about our workforce research and strategy services, please visit our website and use the contact form to get in touch with us. Hannah's going to drop that link in the chat. You can also reach out to me directly after this webinar, and we can set up a time to talk and hear more about your needs. So with that said, I'd like to turn the floor now over to Andrea so that she can provide a detailed overview of the federal policy landscape to sort of set the stage for the rest of the webinar today. So Andrea, the floor is yours.
Thank you. So today I will give you an overview of what is occurring in Congress, particularly as it relates to direct care workforce. The focus will be on the reconciliation activities that you've probably heard a great deal about. To start, I'll just give you a very brief overview of LeadingAge. We're a national association. We have 5,000 nonprofit aging services organizations and members in 38 states. So we support older adults aging in place wherever they call home. Workforce is one of our primary issues for our members, and certainly the direct care workers are those that we hire in much greater numbers. I want to just share for you, next slide. LeadingAge has a series of white papers and reports that we have released over the years that focus on workforce. And if you, there you go back one more, that's it. Wanted to just point out in our most recent paper, it is one that we have highlighted, in particular, increasing the pay of direct care workers, specifically for a living wage in their state of residence. We also have career advancement as one of the priorities, including training and education. Next slide. So before I kind of go into what's happening as far as the reconciliation package, I thought it would be helpful just to point out two of the provisions that were enacted in March that are part of the American Rescue Plan Act. And that was the 10% FMAP for Medicaid HCBS. In addition, we have noted that a number of states have actually implemented their plans. So they're so far, according to Advancing States and their analysis, we have 18 states that have actually implemented requirements for the funds to be passed to direct care workers. 12 states have supported initiatives to raise awareness of direct care jobs. The other point that I wanted to, or provision that I wanted to point out, was the $360 billion in state and local government aid, and in particular, how states were able to use those funds for eligible workers who are doing essential work. Next slide. So when we look at the president's agenda, really both of these plans are ones that have built into the reconciliation proposal that we have that's being debated in Congress. The first is the American Jobs Plan. So while that was the traditional infrastructure, it also included the $400 billion for Medicaid HCBS. Then there's also the American Families Plan, and that is often referred to as the proposal that was most important for economic plans around middle income, or should say middle class families. Next slide. So when we are building on getting to the Better Care, Better Jobs Act, Better Build Back Better Act, this is the reconciliation bill that's being debated currently in Congress. So it takes both the human infrastructure proposal as well as the American Families Plan and the American Jobs Plan. So they both, as well as current legislation, have been melded together to give us the Build Back Better Act. It's a tongue twister. So we have several provisions that are important to aging services, and particularly that impact the direct care workers. Next slide. And this is just an outline of several of the provisions that are included in the Build Back Better Act, just giving you an itemized list of what's there. Next slide. So the first provision that I'll point to that's in the Build Back Better Act is the direct care workforce recruitment and retention funding. And so we have funding that has been allocated specifically for training and recruitment of direct care workers. This is a proposal that has melded together two bills that were introduced in the House and the Senate. So a total of $1.5 billion over 9 fiscal years would be available for competitive grants, specifically again, that can be used for direct care worker wages, implementing training and education programs. I'll also share that nonprofit organizations, state governments, and an array of other entities are eligible for these particular grant programs. There is also $5 million specifically for direct care workforce technical assistance that would help to facilitate these grant funds. Next slide. And what probably has been most commonly, I would say, discussed is the $190 billion for the Medicaid HCBS expansion. This amount is certainly less than what was requested by President Biden in the American Jobs Plan, certainly being less than half of the $400 billion. Currently, the negotiations, as I understand, have taken the FMAP increase in this proposal to a 7-point increase. And so we're waiting to see kind of what the outcome would be, certainly hoping that we can get as close as we possibly can to at least the $190 billion that has passed out of the House Energy and Commerce Committee. I did want to just emphasize that these grants are very important, in particular to a direct care worker, because in order for states to get the increase in the percentage of the FMAP, they have to adhere to an array of different services that would be a part of their improvement planning grants. And most importantly, they would have to update payment rates every 2 years for direct care workers or those that impact the HCBS area, as well as indicate how they're going to improve workforce recruitment and retention, specifically for HCBS. And there's also provisions that would ensure that the increases in the HCBS rates are passed through to workers to specifically improve their compensation. Next slide. I also want to highlight that there are provisions at this point. There are $1.2 billion that have been allocated for specifically long-term care workforce training initiatives. They're titled the Nursing Home Worker Training Grants. And so while it states in the title, nursing home worker, They are eligible for all aging services providers. The funds specifically have criteria in how they should be used. Wage subsidies is one of the areas identified, as well as tuition assistance and affordable and accessible childcare. The funds also require a number of different optional types of services, and among those are they would also be able to have in place a family and medical leave benefit or a paid leave package that could be up to 2 weeks of leave per year. Next slide. And the next is funding that has been allocated for the Health Professionals Opportunity Grants. And this is $425 million for 5 years. They're competitive grants. The objective is to ensure that there are at least 2 of these grants in every state. Currently, I think there are about 30. They've been around for several years. They are specifically in place to help low-income individuals, particularly in the Tenets program, receive training for high-demand healthcare jobs. And the benefit of these particular grants are that they would very much be proposals that also allow for support services to be a part of the initiatives. And just pointing out, the CNAs, home health aides are some of the most frequently trained healthcare workers that are part of this program. Next slide. And just finally, wanting to point to the funding that the additional funding that has been allocated for or through the Older Americans Act programs, in particular, the $655,000 that has been allocated for HCBS supportive services. There is a requirement that those funds be used specifically for workforce recruitment or worker recruitment initiatives, as well as some of the other infrastructure investments that are needed. There are additional criteria I think that will be helpful also under the federal federal apprenticeship program. So in conclusion, we're in a position where, next slide, we have several initiatives that would directly impact direct care workers and long-term care workers as a whole. However, we're not certain what may be negotiated at this point. There are currently continued negotiations that are taking place. As some of you may be aware, the objective is to pass an initiative that would allow for that $3.5 trillion total package, price tag on the Build Back Better Act to be negotiated down. And as well, I would just want to point out that it's not likely that the vote that was expected during, I would say, the month of October on the final plan is going to be negotiated. So that deadline very well may move back. So it could be November, but all in all, I think that these are the provisions that we're hoping will prevail as the negotiations move forward in the process. Thank you.
All right. Well, good afternoon, everyone. I'm excited to follow up just a little bit from a state's perspective. It's so exciting to see the many funding opportunities that may be on the horizon. I think they reflect a growing understanding of the importance of this workforce and a growing commitment to doing what it takes to really support this workforce in order to ultimately be able to deliver high quality long-term services and supports to the many people that we serve. So I do want to dig into the opportunity that we know is immediately before us through the enhanced FMAP funding for home and community-based services. And if we can just jump to my first slide, I want to talk just at a high level about what we're doing in Tennessee. We expect to receive several $100 million through this enhanced HCBS FMAP by the time we get to rematch some of that again through the way that we spend it to provide additional home and community-based services. So I'll talk a little bit about the dollars and about how we intend to invest them in three major areas. One of those is focused on providing more services to the people who need them. A big focus is around that HCBS workforce, which is mostly what I'll talk about. And then related to that, building provider capacity more broadly beyond just the workforce. All of that with an eye toward obviously providing really high quality services to those who need them. Just a quick mention on this slide, because I won't address it anywhere else in my presentation. I do want to just call out the importance of offering access to enabling technologies. I think this is one of those areas where we can provide a benefit that will increase safety. It will increase independence in the home and across community environments in ways that improve people's quality of life, in ways that reduce burden on both unpaid and paid caregivers, and on ways that really allow us to better leverage the limited workforce resources that we have to be sure that we are using those resources when people most need them in order to be able to do the things they want to do in their daily lives. So let's turn to the next slide, and I'll give you a sense of how the dollars are going to flow, we think, in Tennessee. We're projecting that we will spend almost $200 million through this enhanced FMAP plan related to workforce development and provider capacity building investments. And then we're expecting to spend around $240 million in providing additional services to people, either through waiting list initiatives or through increased access to benefits, including that enabling technology that I talked about just a minute ago. Let's go to the next slide and dig in a little bit more on wage increases, because this is a really important focus for us. We are proposing to spend about $137.5 million over the roughly 2.5-year period to provide provider rate increases that will be passed through as wage increases for that frontline direct support workforce. We're targeting these increases only for services that have a direct workforce component. Again, it really is about wage increases and investing in that frontline workforce. And we're doing that with an eye toward really trying to align payment across all of our Medicaid, HCBS programs and populations, but we're paying essentially the same money for the same service in order to be able to support an equitable wage for the people who deliver those services. There will be a requirement, as many states are doing, that those funds are passed through by the provider for wage increases to that direct support staff. Our legislature has a history of doing this in Tennessee, really making sure that provider rate increases are finding their way into the pockets, literally, of that frontline workforce. But we do provide a wage factor that helps to account for the additional provider-related cost, such as taxes that would be incurred in a wage increase for their staff. We intend to make these retroactive to July 1st of this year so that they'll be effective for the full fiscal year. And are working to try to make sure that once the federal funding expires, unless some of these other funding opportunities come in to fill in the gaps, that we can find a way to make sure that those wage increases are sustained through another recurring funding source. Overall, we believe that by paying a higher wage, we'll be able to support providers in their recruitment efforts, their retention efforts, make sure that from a member perspective, from a personal perspective, people have access to the care they need, to consistent staffing, and overall, it just benefits everyone if we're able to pay this workforce more. But we also understand, if we turn to the next slide, that simply paying more is not enough. And so since 2013, 2014, we've been working on a workforce strategy that encompasses, yes, being able to pay the workforce more, but also encompasses opportunities to build competency-based education opportunities, to develop education and career path opportunities, and to be able to collect data that will help us drive our workforce development efforts. Next slide, please. Just a little bit about data measurement. Stephen talks a lot about this. This is one of the things that PHI does so incredibly well. We certainly recognize the importance of being able to collect statewide workforce data. We want to collect that at a statewide level. We want to collect it by program. We also want to be able to collect it by provider so that providers have their own unique workforce data to help drive their own improvement efforts within their own agencies. So we have an annual survey process that is supported by the University of Minnesota's Institute on Community Integration. That includes provider-specific analysis. It includes training and technical assistance, which really supports providers in knowing how to take specific steps that will help to improve their organization's workforce recruitment and retention efforts. And then finally, we've engaged those same national subject matter experts to help us support providers in learning about evidence-based practices that will help them in those same efforts. So what do we do to help identify, recruit, and retain high-quality staff? Next slide, please. I want to talk just for a minute about our workforce development training program. This is something we've invested a lot of time, a lot of resources in. We recognized pretty early on that we wanted a new and better way to be able to really support education and training and development of the workforce. And we wanted to do that in a way that would build both an education path and a career path. So these are the tenets of that system that we've been working on for a long time, making sure it's competency-based, making sure that it includes the ability to earn credits and a post-secondary credential, making sure that there's a demonstration of competency and a micro-credentialing system that really visually acknowledges the additional capacity of this workforce as they move their way through that training program. Next slide, please. For us, we were very grateful to be able to receive federal SIM grant dollars, State Innovation Model grant dollars that we use to help us develop a comprehensive competency-based workforce development program. We were able to bring in national subject matter experts from all across the country to help in building that program, which employs evidence-based practices in adult learning. So really working with people who understand how to design training around an adult workforce. It does correspond with the direct support workforce competencies that CMS laid out in 2014. And it's really been built to support people who are both working and learning at the same time. So they can complete all of the training online. They can complete it in very short segments, and then they can take the things that they're learning into the work environment and actually receive additional credit, if you will, for applying that learning in the course of their workday. We've worked with our Tennessee Board of Regents to award 18 hours of college credit and a post-secondary credential for completion of the program, and to be able to embed that within a variety of higher degree paths for people who want to pursue that higher level of education. The goal has been long to roll that out through our community colleges, our colleges of applied technology across the state, leveraging some last dollar funding sources that we have in our state that really makes education financially available to almost anyone who would want to be able to pursue that. Next slide, please. This is just a quick look at the micro-credentialing system. So these are literally little badges. They're small pins that when pinned all together form a small quilt to demonstrate that a person has completed each of the competency areas and earned their full quilts badge and post-secondary credential. Next slide, please. The way that we had set this up originally was that we were going to pay the wage increases for a person who is working their way through this training program through increases in the Medicaid reimbursement structure. We had actually received approval to do that from our General Assembly, and we were poised to launch that when COVID hit, and we ended up losing the funding to be able to do that. So instead, we are leveraging our ARP enhanced FMAP funding to be able to do much the same thing, but in a slightly different way. And the slightly different way is that we will be working with providers who are willing to offer these pay increases for their staff. This is above and beyond the dollars that we are intending to invest just in wage increases. So these are more opportunities to earn even higher wages upon completion of the training program. And for providers who are willing to make those investments, we will then use the ARP funds to reimburse the cost of the higher wages for the first year. What that looks like for a person is that once they've completed all of the 18 hours of college credit, it's an additional $6,000 per year in wages. And we will reimburse those $6,000 through the ARP funding for the first year, with the expectation that the provider then continues that. What we know is that the cost of turnover, the cost of overtime that results when there is constant turnover, we believe will be sufficiently offset by those provider investments, such that this will actually be a win-win for them. Next slide, please. And then I would just add that all of these investments are in addition to some other things that we're doing that are really focused around that provider capacity, and which offer additional opportunities to providers who are willing to serve additional people to offset some of their initial development costs related to that. It will also offer additional workforce development opportunities and other provider capacity building incentives for doing things that we ultimately believe will lead to higher quality services and higher quality outcomes for the people that we support. So with that, I will turn it over to Jess to talk a little bit about the great work they're doing in Maine.
Excellent. Thank you so much. And thank you, PHI, for hosting this conversation. I have learned a lot, and I'm really excited to take some of the things that I've learned already back with me to our group that's working on these issues. You know, I'm excited to be here today, and actually wanted to say at the outset that our state is using the LeadingAge framework for workforce. So excited to hear from Andrea and be more connected with her. And also one of our recommendations is related to something that Tennessee is doing. So I'm very excited to hear how the last part of this works in relation to paying for these quality metrics. So I also wanted to say at the outset, first of all, I'm sorry, I don't have a PowerPoint presentation. I actually experienced a little bit of a personal emergency last week, so didn't have time to create a PowerPoint. Also wanted to say that much of the work that we're doing here in Maine is connected to a report that was issued by the Commission to Study Long-Term Care Workforce Issues that issued its report early in January of 2020, and I'm dropping that report into the chat in case anybody is interested in seeing that. And just wanted to offer a little shout out to the lead legislator on that commission, Representative Jess Mauer, who is here with us today. Also, before I really dive into what we're doing here in Maine, just want to do a little bit of level setting because Maine is experiencing a little bit of a different challenge than some other communities, although some other states are right there with us. So we're actually the oldest state. Maine is the oldest state in the country by median age, and we actually have one of the smallest, if not the smallest, working age population. And so just to set this in context, about 86% of Maine's direct care workers are women. And in Maine, Maine's working age women compared to people over the age of 65 is 1.59. In other words, they're essentially 1.6 working age women in Maine for every person over the age of 65. And that is just focusing on our older population. It doesn't include people with intellectual disabilities, people with behavioral health children, or even kids who need access to early care. All of those populations typically served by women. So basically, we just don't have enough workers in Maine, just period. And we also don't have enough workers in Maine to generally meet the needs, the care needs of our populations. And so again, are experiencing this in a little bit of a different way than other parts of the country. And I have taken to say, you know, we're sort of way beyond crisis. And we were kind of looking at crisis a couple of years ago and are really starting to see the long-term impacts of not being able to find a sufficient number of workers. So the kinds of challenges that we're experiencing really led us to forge an alliance this legislative session of advocates who are working across all settings that support older people, plus those who are working to support people with intellectual disabilities and those with behavioral health challenges. And we came together and called these workers essential support workers. They're essentially workers who are doing the same kinds of work supporting people living in their homes in communities or in community settings, residential care. And we work together to establish a Maine Care reimbursement rate floor this legislative session that now requires the labor portion of our Medicaid rate to be set at a minimum of 125% of minimum wage plus required taxes and benefits. And this is, you know, really a step in the right direction, but it's not enough, and we know that. And we did this working together because of our tight labor market, but really understanding that if we focus attention on one set of workers, for instance, personal support specialists, and we focus on just one setting, for instance, in the home, and we increase their wages and benefits and quality jobs, that then we're pulling workers away from other populations and settings. And again, that's because we have a very small workforce generally. This was a real awareness, and there was a lot of support by the legislature for the fact that we have to solve these challenges really collectively as we're thinking about this workforce and really thinking about this workforce all as one. So really to look at how we are beginning here in Maine to mitigate some of these workforce challenges with this enhanced federal funding we're receiving, you know, we're going to be doing some very specific things like a media campaign. This fall, the Department of Labor, Department of Economic and Community Development, and the Department of Health and Human Services will launch a multimedia public service campaign promoting direct care worker jobs and specifically including them as sort of the on-ramp to healthcare jobs. And that's something that's really never been done before in Maine, connecting these direct care workforce jobs directly to all kinds of healthcare jobs, and that is part of a career lattice and career pathways work that's also being done in our state. The focus will really be on new Mainers, racial and ethnic minorities, men, younger people, older people, and people with disabilities as people who are really have not been a focus of, in Maine at least, of folks who are taking these jobs. And this funding will also have funding to do additional outreach to different populations once we learn directly from frontline workers and direct conversations we're going to be having with them that will influence a longer campaign. I also want to say that we're using ARP money to hire 2 navigators into our career centers to help people access stackable credentials, access training, transition out-of-state credentials to in-state credentials, and are also helping to pay costs of training and offering supportive services to help workers get from A to B in their employment process. Additionally, and I think pretty exciting, ARP funds are going to be used for a student loan forgiveness program, for healthcare provider loan repayment pilot. And literally in the statute, direct care workers are specifically called out as a priority population for this opportunity. But of course, these will be loans that were already acquired by someone that they will be able to get loan forgiveness for. They're also, I think, really another piece using the funds to bring on a curriculum designer to look at all trainings across all provider types to create entry-level credentials that can be part of a larger education plan. And the idea here is to make sure that as folks are coming into this workforce in any particular place, that as they are moving along and getting more credentials, that ultimately that fits within some sort of a degree program. And so we're very excited to be looking at sort of what are the basic skill sets of a personal support specialist or direct support professional, and how does that fit within the context of a social work degree or a nursing degree, and how can we then give credit to those folks if they end up moving into one of those programs for the learning that they have already done. We're also using our ARPA funds to create a more robust learning management system, which will be used by all workers to basically track their training and licensing. And the plan is to integrate this with our community college system and university system and really create one place that a worker can find all of the information about the training that they've received, and can also more easily communicate with others about how they are moving along in the system. We're working to create a core certification that meets the requirements sort of for all entry-level positions that can be built upon. So if you're interested in dementia or autism or behavioral health, then you can build on this, but basically one core certification so that it doesn't matter which population you're working with, that you're able to come in and then move easily from one kind of a license to another. I guess I'm also paying very close attention to the time, so I'm trying to get enough but not rush through it. We're also we're providing, using ARPA funding for frontline direct service professionals in healthcare currently employed. And this is related to tuition remission. So really trying to retain and strengthen the current workforce we have. And so this is a very specific initiative that is working to move CNAs into LPNs and really fast track their movement along or progression along the career path, and also focusing on moving LPNs then to RNs, and really, again, focusing on the lower end and how do we move them quickly into other jobs, other healthcare jobs that we also desperately need. In the fall, we're going to be using, so now we're hoping to be using the enhanced FMAP for both recruitment bonuses. And so providers will be reimbursed for bonuses that they are paying currently to bring workers into the workforce. And also there are going to be a series of bonuses that will be available to workers, particularly who worked through the COVID crisis for the workers. Again, it's a retention strategy. And that's really the idea of those bonuses, is to bridge until this new rate increase takes effect, which it takes effect on January 1st. Another piece that we're doing with the enhanced FMAP is a market analysis of what compensation should look like in this labor market. This 125% floor is a really good place to start, but we need more robust analysis to see what we need to be paying in the future. And then finally, and I think a really cool thing that's happening is that we're going to be conducting focus groups with both home-based care workers as well as nursing home workers to understand what would make a difference to them. This will be asking what kinds of incentives are important. Do you need childcare? Do you need housing assistance? Is tuition reimbursement a good thing, or do you need tuition credit? Would a microloan process work? These are all questions that we're going to be asking through this part of the process. I seem to be running out of time, so I will mention sort of just more broadly, that's the kinds of things that we think, really still need to be done because we're really beyond crisis, as I mentioned, is thinking about how to use the ARP funds to create immediate structural and real incentives to get people to choose this job over any other job, and certainly to increase their pay. We think incentives need to be diverse, have to include childcare subsidies, housing subsidies, transportation subsidies, as well as some sort of tuition credit, either for the person or their family members. Obviously, ARP funds would allow us, if we use it that way, to pilot these things to really see which of these incentives are most impactful. We also think beyond the workforce navigators that are considered, that we should be going further and really creating workforce navigators that are helping workers in these jobs and new workers that come in take advantage of all the benefits that they might be available. We do benefits counseling with older people. We should be doing it with younger people as well. Make sure they're taking advantage of training, help them navigate through the career pathways and to healthcare jobs if that's where they want to go, but also understand how they can move within the setting if this is a job that they just love. Finally, I will say, I think beyond a market rate analysis, which is critically important, we also have to know how many workers we need. We have literally thousands of people on the wait lists to gain access to services. We have 10,000 hours of unstaffed home care that go undelivered every week, 10,000 hours that goes undelivered every week. We have whole wings of nursing homes closed. We are warehousing literally hundreds of people in hospitals right now who can't be discharged to home or to residential care for lack of workforce. And so we have to understand how many workers we're going to need to add to our workforce to meet current demand and anticipated increases in demand. And we're going to have to create a plan for how we're going to get these workers into this workforce. Finally, I think we're often missing what happens to people when they don't get the care they need. And we have to understand what the cost is to not just individuals, but also to our economy through increased expenditures in healthcare and in long-term care. So I will leave it there, understanding we've got only 3 minutes until we're done, and maybe have just a few minutes for questions.
Great. Thank you so much, Jess, and to you, Patti and Andrea, for all of that wonderful content. I think my main takeaways are first that, as Andrea described, this is a pivotal moment for the field, not just because of recent investment, but because of more funding coming on the way. And then Jess and Patti, I think my main takeaways from what you described is the importance of both recruitment and retention of these workers. And with regard to training, the importance of developing career pathways, transferable credentials, and the infrastructure to support all of that. There were a few questions that came up during the chat. We'll maybe have time for one or two. If we don't get to your question, feel free to email me at smccall@PHI National. I'll make sure to coordinate with the panelists to get it answered. So the first question, I'd like to sort of expand on it a little bit, is how can I end the institutional bias in Virginia and get in-home attendance the same pay rate as group home attendance? But maybe more broadly, like, how do we consider equity across settings, both at the federal and state level, and enact policies to accomplish that?
Well, that's not an easy question, is it? So first of all, I mean, I think there are things that can be done, obviously, through reimbursement structures to try to take into account equity across programs, equity across settings, equity across populations that we serve. I think what we typically see is that, at least as it relates to home and community-based services, the workforce is generally on average earning about the same, no matter which population they're supporting, which program that's in, or quite frankly, even what the rate is in that program. Because if a provider participates in multiple programs, they're going to pay the worker the same rate across those programs. I think where we do see differences is in institutional versus HCBS. And there are some very fundamental differences in terms of what the federal government will allow as it relates to those payments and what's provided in community. And those are federal policy issues that ultimately will have to be addressed if we're ever to get to a place where we can really truly balance our systems.
Thanks, Patti. Jess or Andrea, do you have anything to add on that? Okay. Great. Well, we are at time. I do want to encourage you. I dropped my email in the chat. So if we didn't get to your question today, feel free to email me. And I apologize for that. But thanks again to all of our panelists today. I sort of selfishly picked you all because you're some of my, sort of folks that I really look up to in the field. And this is just awesome. So thanks for all of the work that you're doing. And thanks for everyone for attending this webinar. To note, this is the first in a series of PHI webinars, so there will be other topics coming up soon, both on policy and practice. So if you're interested in learning more about that, make sure to subscribe to our email list and also follow us on social media for updates. But thank you all, again, to the panelists and to everyone who attended today. This has been super helpful. Everyone have a great day.
Thank you.
Thank you.